get us started. I'm going to try to make sure that I can advance everything the right way. So give me 1 second. Other thing, going to look at the exam to kind of see if anything will be given back. I'm not sure about that yet, so just stand by on that. I don't want anyone to be discouraged because we will have 2 more exams that have less drugs that will be on them. What I do want you to take away from this is that when you get into your next semester, this is kind of the drug load that all of your exams will have moving forward. So just try to keep that in mind as we continue to go through the classes. But like I said, the next one, I have it to where it's not as heavy with the drugs, the next 2. So it shouldn't be too bad. So I just don't want you guys to discredit how much information was on that exam. So we will be fine. We will recover from it. Sorry, I didn't mean to draw on that. Okay, we'll go ahead and let me let everybody else in. We'll get started. So what we're looking at today is going to be our GI meds. These are going to be our medications that we're using for several different reasons. You're going to have lots of different patients who are going to come in need of some of these GI medications. So just making sure that we are familiar with them. When we get to next semester and we start talking about pain, you're also going to hear about these medications as well. Okay. So your ELOs, same thing as what you've always saw. So making sure that you're paying attention to the drug class, mechanism of action of where things are going, your adverse effects, contraindications, like our big interactions that we'll talk about. If there are counseling points that I'll want you to remember, I'll also point those out for you as well. So again, just make sure that you're understanding and going through the big picture with all of these. All right. So name of this game is understanding which disease state we're actually talking about when we're looking at our medications, okay, and where they belong. So the first condition that we're looking at is going to be our GERD, or gastroesophageal reflux disease. So these are our medications that we're going to typically use if your patients are presenting and they're telling you like, hey, I'm having a lot of reflux whenever I'm eating food, or I feel like I have kind of heartburn issues going on. So you have mild, intermittent, and you have your severe or frequent. Depending on how that patient presents is going to determine which medication you're going to use. So again, like normal, I will tell you what they have. I will tell you that they are mild, intermittent, or I will tell you that they are severe and frequent. And if I said mild and intermittent, you're going to be like, cool, I can use an H2RA. I can have some antacids if they're having breakthrough. I'm assessing them on the spot treatment because it's not something that's happening often to that patient. Whereas if I am a severe or a frequent patient, I'm going to put them on a PPI, proton pump inhibitor, and I'm going to try to say, hey, this is something that you're taking every single day. Okay, they're going to be on that medication every single day to make sure that they have a response and that they're decreasing their symptoms that they're experiencing from the GERD. We do not want to keep patients on these medications forever if we can prevent that. There are some times where patients will be on these medications for a very, very long period of time. So when we talk about this, just make sure that you understand, hey, there are some patients who are going to be on there and we are not going to be able to get them off, and you will see those patients. But make sure that you're following up. Most of your patients who have been on these medications for a long period of time are because we forget to follow up with them to take them off of these medications. So you see that when you have that improvement resolution, so if I have a partial response, I can give them a different medication. I can change how frequently they're taking that medication. I can adjust their timing according to the dose, according to when they're eating their meals. And then if they have a full response, right, meaning they're like, hey, doc, I don't have any more GERD, I'm not experiencing any of those issues, then what you would do is you can try to trial them off of the medication. So you would be like, okay, I'm going to pull off that PPI. I'm going to stop you with this H2RA and say, let's see how you respond now. If those symptoms respond, then you're going to probably put them back on the medication, but you can also kind of look further, more invasive with that endoscopy and see if there's anything else that's going on. So we're going to go through these medications so you can see what a H2RA or a histamine receptor antagonist is and what your PPIs are, which are your proton pump inhibitors. This next slide is a very good summary slide of where your drugs are working, okay? So just refer back to this so you can kind of say, all right, if I have this drug, what is it doing? Where is it working? What is it trying to do? So when we look here at your H2 antagonist, this is what we call our H2RA. You see that they're trying to go against that histamine response that our patient is having. And then when you're looking at your proton pump inhibitor, oh, wow, there's a proton, right, that's being pumped. So if I inhibit this proton pump inhibitor, I'm decreasing the amount of acid that they have. And of course, your antacids are just trying to bind, right, to that acid that's floating around and decrease how much discomfort your patient will be feeling. So this is, again, looking at all of our different acid reducers that we have and like their mechanisms for you to see where they're working, how are these drugs acting on the parietal cells, how are they helping me decrease my symptoms. So you have several different classes, all of which we're going to talk about. So again, a good summary slide for you to look at and say, hey, where are my drugs working? They will be on the slide for you to see it. But just understand that you also have the option to come back here and say, all right, where is this working? What is this doing? Okay, so our lowest threat, unless someone is eating these like candy, but they kind of have to because they take them very, very often. So 4 to 6 times a day, you would have to take an antacid. And essentially what you're doing with these are you're trying to say, hey, I'm going to give my patient this weak base to react with that acid so that it can form some salt and water and kind of neutralize the amount of acid that somebody is experiencing, okay? So therefore, we have less pressure that patient is going to be experiencing. So when you're seeing your lower esophageal sphincter pressure, that's that pressure that makes someone kind of feel like, oh, like that, feel the burn, or like they have to vomit sometimes. So that's what we're trying to do with our antacids. Very effective medications over the counter. We also have them in the pharmacy. If you want to order them for your patient, you definitely can. Again, like I was telling you, adherence-wise, they are taken very frequently, 4 to 6 times a day. Food doesn't matter, but these are those same medications that we were talking about where we're like, hey, you got to make sure you're separating these with some of our other drugs, some of our other antibiotics. Next semester, you're going to hear more medications that we're worried about the chelation with these irons that you see, so your magnesium, your aluminum, your calcium. Also, you see that these are for your patients who aren't very severe, right? So mild to intermittent symptoms. These are your patients who are going to go out and they're going to say like, oh, yes, I have an H2RA, or yes, I have a proton pump inhibitor, but I'm experiencing like some breakthrough and they're going to need some medication. So this is what we typically will give those patients. Looking at our PK, so very, very quick acting medication. So you will see that a lot of people love to take them. They do have a funny, like chalky kind of texture to them that some of your patients may not like. So a big one that we think about when we're looking at these are like some of our Tums, our Alka-Seltzer, things like that. So kind of keep those in mind whenever you're looking at your antacids. You see that you can give, and this is depending on the drug, 1 hour after a meal, and they can have some very good suppression for a longer period of time if they are taking a higher dose. The issue with you taking a higher dose is that you can see some more of these side effects, and it depends on which formulation they're taking, right? Because we have several different formulations of our antacids. So if you look at aluminum or you look at your calcium, those cause constipation. So remember, like calcium has a C, constipation. And then when you're looking at your diarrhea, your magnesium is going to make them go. Okay? So that you can kind of remember those adverse effects. They're unique to the formulation of the antacid. And then looking at this accumulation, so all this is essentially telling you is that you need to make sure if somebody has renal dysfunction that we are adjusting for that. Our interactions. So several interactions like we just talked about before. Some of these we saw in that last block that we just did. But what you're seeing is that there have chelation properties where they will bind to some of our medications and they will decrease the absorption, which will therefore decrease the effectiveness of some of our medications that we're having. So you see here the fluoroquinolones, our tetracyclines, you see that you can have an increase in pH, so that could affect some of your other medications that want to have a lesser pH to be absorbed. So you can see now those medications are having decreased absorption, which could then lead to toxicity or treatment failure, depending on what you're looking at in that patient. Your increased absorption that you can see with your glipizide and your ibuprofen, those are just simply due to the fact that, again, I am increasing now how much of that medication I have actually, I've absorbed more than I wanted to. Okay, so therefore that's why you see in that toxicity. So whenever we're looking at these, we want to avoid these medications and separate out our timing of when we're going to give them, right? So if you can put them on something that doesn't interact, if they don't need an antacid, but most of your patients who are on a PPI or H2RA, they're going to have antacids for breakthrough. So we want to separate those times, okay? So just make sure that you're paying attention to the fact that there is a time gap in between when they would be taking these medications. Looking at the different medications that we have available. So I was telling you that depending on the formulation and how they make these medications will vary with the side effects that you're going to expect to see. So when we're looking at our sodium bicarbonate, which is the same thing as baking soda or Alka-Seltzer, you see that essentially what it's trying to do is it's reacting with that acid to produce the carbon dioxide and the sodium chloride, and therefore you're going to buffer out or decrease the amount of acidity that we had in the stomach, which could potentially be leading to the reflux that they're experiencing. But because of that, the CO2 that has been produced from that reaction, you'll see a lot of bloating and gas that ends up happening with these patients. So therefore, thinking about your adverse effects, right? If I have gas, I'm thinking about, burping. I'm thinking about it coming out the other way. A lot of maybe GI distress because in pressure, because if I can't get the gas out, we'll sometimes feel that. Looking at the cautions that you see, looking at the cautions that you see, making sure that we're not going to be trying to use this as much in our patients who had that renal insufficiency or pregnancy. When we're talking about our pregnant patients, remember that we have aspirin that will be in our Alka-Seltzer, okay? So that's why we also watch out with this, because we don't want our kids to have any of that aspirin. Looking at your caution in your patients with hypertension and CHF or congestive heart failure, HTN is hypertension. With that, we're worried about the sodium, and there are several different drugs that will affect those levels, and that's a very important ion that we have that can affect things. So that's why we are watching out for our patients with hypertension or CHF. Your mechanism of action for your calcium carbonate, very popular Tums, tum to tum tum tum. Remember that commercial? Still comes on. People still take this medication a lot. So remember when we were looking at the previous slide, they have it 4 to 6 times a day. Most of your patients are going to be taking this whenever they eat something. So with this same kind of idea with how the mechanism is working, decreasing that acidity because it's binding that free hydrogen. You'll also see that you have increased GI motility. So for some of your patients who are going to have some issues with like motility, their GI tract isn't moving very well, you will see where this will get that peristalsis going for them. Very well tolerated for the most part, but because of that, getting some things moving, right, increasing the motility, you can see where some of your patients will experience that constipation because they're able to get enough water absorbed into that GI tract for them to not be constipated. So things are kind of going through and not getting the proper absorption that we would want to see that occurring. With your binding and your chelation, same thing that we already kind of talked about before, okay, with the chelation and with our antacids. All right, your magnesium hydroxide or milk of magnesia, also available over the counter. We do have this in the pharmacy as well. We can use this for an acid. We can also use this sometimes as a laxative. So what this is doing is, again, forming that mag chloride in water so that we can neutralize the acidity that we're having. Looking at our adverse effects, because some of those magnesium salts may not be absorbed, the magnesium is going to make them go. So that's why you see the diarrhea. Okay, watch out for your patients who have that renal insufficiency. We see that this is becoming a theme with that renal insufficiency. Your aluminum hydroxide, we're looking at this one, just seeing again that we're trying to react with the hydrogen ions, right, to form the AlCl3 in water. A big one that we have here is Mylanta in simethicone. So again, over the counter, that Mylanta is very thick and like a chalky solution. So you will see now with some patients who don't like that texture or a minty flavor, which they're coming out with different flavors. We have Gaviscon that's also available. That one is more of a tablet for the patients, which some of them like. Slightly different mechanism that you see here. So your Mylanta is using that simethicone to decrease the amount of gas that patients are experiencing, whereas your Gaviscon is reducing the amount of reflux that your person has coming up. So just remember the overall mechanism and that these two things are working in two different ways. Because we do have that aluminum, just like we talked about with our calcium, we were worried about constipation. Renal insufficiency pops back up again, right? So looking at this chart, this is just a summary of all of the things that we just talked about, giving you the kind of the quick and dirty of everything, but on just one slide. Making sure that you also are seeing that we had that drug-to-drug interaction. Some of those are listed down there at the bottom for you to see. So on your regular slide deck, you should be able to see it, and if not, just let me know. But it's just showing you like the drug-to-drug interactions with some of our other irons that they could be taking, other medications that we talked about on the previous slides. Looking at your H2 receptor antagonist or H2RA. These medications are very good medications. We have them over the counter. You can also prescribe them. And we have them in the pharmacy. So what they're doing is they're essentially blocking the histamine binding H2 receptors and stopping that acid secretion. So therefore, again, we're reducing the amount of acid that somebody is having in their GI tract, and therefore we're decreasing their symptoms and hopefully their reflux. Clinical uses, there are several different things that we're going to use these medications for, 7 different disease states. So just kind of look over those. A lot of the times in the hospital, when you get there, you'll see famotidine used a lot for that stress ulcer prophylaxis. But again, these are over the counter and available for a lot of people who have a lot of GERD and those peptic ulcer type diseases. Depending on your patient, depending on how they're presenting, will depend on which medication they choose, and we're going to go through some different options that they have available for them. But the thing with these and them being over the counter is kind of an issue is because patients are allowed to go and pick whichever medication they want. But the longer that they use them, the more they are likely to develop tolerance to the medication. So once you start to hit over that 2-week time frame, and some people as soon as 48 hours, you can see this tolerance. This is where people will say, like, hey, they're ineffective. So you just try to get them off of the medication and then have them continue to resume after they've been off of it for about a week or two, and then have them try to restart. These are not as potent as our proton pump inhibitors, but they are safe in pregnancy. So we do see these, again, used a lot, and especially in our inpatient setting for that stress ulcer prophylaxis, you will see these as well. So big thing here, the longer they're on them, the more likely they are to experience that tolerance, which means then the medication is not working when you hear tolerance. So our adverse effects, pretty well tolerated for the most part. We have some CNS effects, some sexual dysfunction, gynecological type issues. So the gynecomastia is where you can see, and specifically looking at our cimetidine for this, is where you can see the enlargement of breast tissue. And sometimes it can be very painful, especially when it happens in male patients. And then we talked about sexual dysfunction with some of our other medications. So just making sure that you're understanding that is a big deal for some people. Just let them know. And we have several other H2RAs that we could switch a patient to. So it's not like they have to be on the cimetidine. Your cimetidine are the ones that are more likely to cause the gynecomastia and the sexual dysfunction. Looking at your drug interactions, this is going to interfere with a lot of our medications as far as like their absorption, okay? So they're going to decrease the absorption of any of your medications that is going to need that acidic environment, which is kind of what we talked about when we were looking at some of our antacids, right? Because I'm lowering that acidic, the acidity, and if I need that acidic environment for absorption, now I decrease my effectiveness as well. You also see that there are several different interactions when we're looking at our CYP. So just remember that your cimetidine is an inhibitor. And we'll talk about some of these. So if it's an inhibitor, it's going to increase those levels of those other medications. So when we're looking at something like warfarin, which you'll talk about more next semester, but when we're looking at things like warfarin, what that can essentially do is increase the bleeding risk that a patient may have. So just thinking about that and understanding, like, these can have lots of different repercussions, with cimetidine being your biggest pain, right? So we already said sexual dysfunction, the gynecomastia, now we have cimetidine causing some more of these and having more interactions with our CYPs. It is a CYP inhibitor. So another summary chart, again, for you to look at, showing you all of our different H2RAs that we have available. And then you see with the famotidine, the one that I told you that you'll sometimes see when you're in phase 2 in the hospital. Because of that IV status, especially if you're in the ICU, you'll see where a lot of your patients will be receiving that famotidine. Okay? Now, I also told you previously that a lot of your choices would be based on how is that patient presenting, and also if they have insurance, right? So if I don't have insurance, may not be a good option for me for you to put me on Axid or Nizatidine, right? Because it costs more. Yes, it is over the counter, but it costs more money for that patient. Again, if you can write a prescription for something, we do have the famotidine and the cimetidine in the pharmacy. I haven't seen that Axid in a while, so I'm not sure if we still carry it. So that would depend on the formulation. But again, make sure that you're paying attention to that first line that you have available there. Don't worry about dosing. Don't need you to remember that. Do look at your mechanism of action. And then those adverse effects, like I told you, very well tolerated. And just remember that tolerance can occur in these patients the longer that they're on it. So over 2 weeks, you're definitely likely to see it. Over 2 days, you can start to see it. Okay? All right, our proton pump inhibitors. These are our big money makers that we typically use. So when we're looking at these are going to be your esomeprazole, lansoprazole, and omeprazole, dexlansoprazole, pantoprazole, and rabeprazole. I want you to note the bottom three are specifically through a prescription only, whereas the top ones, you can get those over the counter. With omeprazole being one of the latest ones that they allowed it to be over the counter. So pay attention to that. When you look at your IV options, you have your pantoprazole as an option. I want to say that Dexilant, they also made an IV, but I'll stick to what's on the slides. Make sure that you're understanding that your pantoprazole is also an IV option that you have as well. So these are like we are sure that they are going to work medications. They are very, very effective. Looking at our mechanism of action and kind of what's going on and why we are using our proton pump inhibitors. So when you're looking at this, you see that you have the production of that hydrochloric acid from that proton pump inhibitor, from the proton pump being activated. So if I could say, hey, let me not have acetylcholine, histamine, and gastrin stimulate that acidic production, I'm going to try to say, with that proton pump, I'm going to say, hey, maybe I can give a proton pump inhibitor. Naturally, our body has prostaglandins, which also try to say, all right, let me stop some of this acid production and try to protect the GI lining. And so this is kind of also a natural combatant against the proton pump, okay? And then we came along with our medications and said, hey, I'll do you one better. I can make this medication that can also inhibit the proton pump. So most of the time, these are prodrugs, and what they're doing is they're binding irreversibly to that pump to try to say, hey, I want you to stop secreting any of these hydrogen ions that you have, and therefore I can decrease the acidity that that patient is experiencing. Okay, so it does take a little while for them to work. They're not as quick as some of our H2RAs or iron acids. You see that it's taking 2 to 3 hours, but they last longer. So if I have something that lasts longer, that means that I don't have to take it as often, which is also a plus. So a lot of times with these medications, you'll see our patients will take them once a day, sometimes twice a day. But the benefit here is, again, I'm losing something, right? I'm losing that quick onset, but I am getting a longer duration. So these are typically for our patients who have frequent, and that's why you saw it on the chart on that frequent side. These are your frequent flyers that you're going to use your proton pump inhibitors on. So you see your dyspepsia, your GERD, all of your different indications. When your patients are on NSAIDs for a very long time, you can sometimes see ulcers. We'll talk about that next semester, that are formed. So you can have this medication on board to try to prevent them from having an ulcer form when they're taking those NSAID medications. If you also have somebody who has H. pylori, this is going to be a part of that treatment. We talked about the H. pylori treatment last block. So again, now you're getting to see your proton pump inhibitor here. Talking about when you should take them. So the time in relation to meals, because we do have that slower onset, should kind of make a little bit more sense for you. Because I'm taking about 2 to 3 hours to work, now I need to take it at least 30 to 60 minutes prior to me eating something, okay? So don't think that someone is going to have immediate relief from this. If somebody is coming to you and they're in pain at that very moment and they're wanting some relief like immediately, and they don't want to wait for this to hit like that higher concentration, which is, it could be 24 to 1 day to 4 days for that concentration to be met, you can give them something quicker like your H2RA. You can give them an antacid at that point to try to help with those symptoms right away, because they're not going to see that immediately when we're looking at our proton pump inhibitors. You will see people left on these medications. We put people on these meds and we kind of forget about them and we just refill it because they get used to it. But remember, we don't want to leave them on these medications. We want to try to say, hey, I'm going to put them on here On here it says 1 to 2 months, but sometimes you'll see up to 3 months. And if I have my patient controlled after that 3 months, I'll pull them off. And I'll say, hey, all right, let's see if we can trial you off of this and see how good you're doing. So for the most part, just stick with what the slide says. You'll see that 1 to 2 month time frame that you're going to put your patient on this medication. And then we're going to say, hey, I want to see if you can do without having this proton pump inhibitor on board now. And you can try to take them off. Again, if they experience those symptoms again, you just put them back on it. And then, again, we have several different options in trying to limit that OTC use to the 2 weeks like we just talked about with our H2RAs. All right. Well-tolerated medication, which is why a lot of people love them. Very basic things. So just make sure that you're understanding that the two that are kind of weird here are your acid rebound and your hypomagnesemia. So when we're looking at that, it's kind of like I am suppressing the acid, right, that somebody is experiencing. And then your body is saying, hey, but I'm supposed to have these, right? Like I'm supposed to have this, this acidity. So the body will go into essentially overdrive. And then if y'all are putting comments, because I'm trying to work off of one computer, I will try to answer them as I see them go through. So give me a second it's trying to open up the chat over here. I just see that it's highlighted. So give me a second. So looking at our interactions that we have for our proton pump inhibitors, big things that you're going to see here is, again, anything that we're thinking about that needs acidity. So those same drugs that we talked about before with the acidity are what we're worried about now. When you're looking at your omeprazole and your lansoprazole, those are your biggest and strongest inhibitors that you have. So if you are worried about inhibition with those SIPs, and just remember SIPs, I don't need you to remember it's 2C19, your omeprazole and your lansoprazole, which are two very, very common ones, are going to be your highest offenders. Let's see. We'll talk about clopidogrel or Plavix in the next block, but just understand it again. Big thing I want you to take away here, several interactions. We're worried about the fact that if I can change that pH, then that's when I'm worried about the fact that they're not going to be absorbed properly. Again, a summary chart telling you the big things that we want you to kind of know about and looking at which ones are RX, so prescription only, versus the ones that don't have anything next to it means that you can get them through prescription, but they're also available over the counter. Don't worry about the doses. Mechanism of action is, again, summarized here for you, making sure that you're also looking at the your onset taking a while, right? So if I need some immediate relief, then I'm going to want to give them one of my antacids to kind of help them. Or if somebody needs one of our H2RAs, those work a little bit quicker as well. So that onset typically being around like 5 minutes or so, where they can see a response from the from our H2RAs. So good summary charts when we're looking at these, okay? Well tolerated. The only thing that I was telling you kind of weird that was here was that rebound, hypomagnesia, drug-to-drug interactions. You see everything that has decreased clearance. So that means that it's going to build up in my body more versus my decreased absorption, meaning that it's not going to work as well. Of note here, and I want you guys to pay attention to these because these are a little bit different, and these are situations that you will probably need to use these medications with. So these are several different options that we have that are available for our patients, especially if they are in a state where they cannot swallow pills. We have several options for us to help treat them, right? So for our sprinkles are really good because that helps us with our kiddos. This helps us with a lot of our older patients as well, with them being able to tolerate and take these medications properly. ODT is that orally disintegrating tablet, so they'll put it in their mouth and it will just disintegrate. So if somebody does have issues with swallowing, especially if a patient has GERD, is potential that they could experience that. This is a good option for them. Your OG-NG tubes, these are your patients that are going to be in your hospital, likely in an ICU setting, or they could be a situation where you have a patient who just, like, for whatever reason, they have that tube, they have that NG or OG tube, and so you can give them those medications that way. Looking at your do not crush. So this is important because this is going to come up when you're in this hospital setting. And if you get confused, not on the test, but in the hospital, you can go look it up, or you can ask the pharmacist, all right? There's also several tools online that give you like a do not crush list. Some floors in the hospital will have those lists there, but for the most part, you're thinking like, hey, I need to make sure that I have these medications not being crushed, because what sometimes we'll do is we'll say, oh, a patient can't swallow it, I'm going to crush it. That's going to affect the PK parameters of the med, so that's why you'll see that we are not crushing these medications. All right, our next slide that we're looking at, and I think what I'll do, y'all, since it isn't taking forever to load for the questions, I'll just answer them when we come back from breaks, because I see now it says 2. Looking at our mucosal protective agents. So again, remember we had those prostaglandins that were trying to help us protect our lining. And so these are, again, some medications that we have that are also trying to do the same thing. So what we're doing is we're trying to take these on an empty stomach because we need the acidic environment for these medications to be activated. They last for a pretty long time. You see that they have 6 hours of duration of action, which is very, very good. It means that I have, I'm not taking it as frequently. Looking at your clinical use, several different uses that you have available. This is not as common as you'll see some of our PPIs or H2RAs being used, but these are things that are available for us. So stress ulcer prophylaxis also there. Looking at the preference and why you don't see this used as often is, again, like if I'm having to take this several times a day, it's not as patient friendly. These tablets are also pretty big. They do not taste great either. And then you also have the chelation properties that we're, again, worried about. So making sure that you have to separate them because of all the interactions and things like that. So when you're looking at this, just think about this is not a first line thing. You would pick either one of your PPIs or your H2RAs, depending on how your patient presented, and then you have your antacids for your mild cases or for your patients who are having like breakthrough and they're on one of those medications. Oh, sorry, the adverse effect, make sure that you're looking at that. Again, the constipation being a thing here for your sucralfate, and that we're worried about the accumulation in your patients who have any type of renal dysfunction. Misoprostol, so this is Cytotec. This medication may be as effective as our proton pump inhibitors in healing our ulcers or preventing them. But what we will see with this is an oral prostaglandin. Remember, we said that those prostaglandins were trying to help protect our lining. So this was protecting us, but we also see that it's helping with that pump and trying to decrease the secretion that your patient is going to have. Adverse effects, diarrhea, some abdominal pain, so those are big ones that you need to take note of. But because of the big controversy, especially now with like abortion laws and things like that, misoprostol is not seen as much, and we don't use it as often. It is still available, but it does have contraindications in our patients who are pregnant because it can cause them to have contractions and potentially have them have a miscarriage. So just make sure that you're not using this in your pregnant patient. Looking at our business subsalicylate. So this is our Pepto-Bismol. This is an antibiotic that we could potentially use, this is a medication that we can potentially use in our patients who have H. pylori, which is where we've seen it before. But there's different formulations of this, so just be aware of that. One is the subsalicylate, which is like looking at aspirins, things like that. So you're watching out for that salicylate toxicity. And then you have your subcitrate potassium version of this medication also. Looking at our mechanism, what we think it does is that we think that it coats and decreases the secretions that our patients will have. We also have some minor antimicrobial effects of this medication. So that's why we can see it used in our patients who have H. pylori. Looking at our clinical use for our patients who, remember the song, for our Pepto-Bismol, and they're like upset stomach, diarrhea. So all of those types of things. The prevention of your childhood diarrhea. If you have somebody who just has diarrhea in general, people who have a lot of dyspepsia, GI discomfort, they will take this medication. And then looking at our adverse effects. We have several different adverse effects. The biggest one that people get more nervous about is going to be that darkening of the tongue and of the stool. So it turns essentially black. And so people are very, very concerned, and they're trying to say, like, hey, is this a bleed? Is it not a bleed? So if it's a time that if they start taking this medication and they're starting to experience this and it's close to that time, it's likely that it is just the medication. We do see that you can potentially have the salicylate toxicity, so making sure that if this is not something that somebody is taking every single day, and that they're avoiding it if they have any type of renal insufficiency, because again, we will have accumulation and more likely for us to see that salicylate toxicity occur, especially if they're using other things that have salicylates in them, which we'll get more into that next semester. Looking at your caution with your anticoagulant. So an anticoagulant would be something like our warfarin that we would use to kind of thin out someone's blood. That's typically what anticoagulants do. And so when we're looking at this, we may see some enhanced effects because this could also potentially thin some things out because of the salicylate properties that it has. Looking at some other agents that we have that are prokinetic agents, so they're trying to help increase that motility. These are going to be like our last line medications where we try to treat our patient with other things and they did not work. So we have metoclopramide, erythromycin, and bethanechol. Metoclopramide is an antagonist, a dopamine antagonist. So some of those adverse effects that you're going to see is going to be some EPS side effects, which are going to be extra pyramidal symptoms that your patient, so they'll have issues with like moving. And we'll talk about this more when we get into like Parkinson's and things like that. So contraindicated in any of your patients who have TD or tardive dyskinesia, or if they have any type of epilepsy history because of the way of the dopamine antagonism. Looking at your erythromycin, we talked about erythromycin already, so just understanding the same thing kind of goes here. Looking at that, we don't want to use it with some of our statins that we have because of that SIP, and that it is an inducer. Looking at your bethanechol, a cholinergic agonist. So again, that's just as simple as I'm going to keep the mechanisms for these. When you're looking at that, just thinking about getting things moving, right? So making things wet. So you have diarrhea, you have flushing. These are all of the things. So if you think about a prokinetic agent, we're using this because we're trying to get those adverse reactions that we're seeing. We want to get those. So contraindications in any of your patients who are going to have Parkinson's because of that cholinergic activity that we have, which we've talked about previously. Coronary artery disease is what CAD stands for in epilepsy, so kind of repeating itself. Your reflux inhibitors that you can see, again, as an adjunct, so you would keep your patients on the medication that you are already giving them and say, hey, let me see if I add some baclofen to this, which is a muscle relaxant. We don't really like to use it. People have lots of different side effects when we're talking about our muscle relaxants, like drowsiness and things like that. So you can see if it does somehow decrease that lower esophageal sphincter pressure, and sometimes we do see a result or results from that. So just keep that in mind. So these are all, when you're looking at these are all refractory situations. Okay, these are not your first-line situations. These are all refractory situations. All right, quick check on learning. And y'all can type these in the chat, which just now decided to open. Which of the following has an IV formulation that is useful for patients who may have difficulty taking pills by mouth? And just while y'all are looking at these, so when you see this, you see that all of these say Prozol, right? So your proton pump inhibitors all have the ending Prozol. So when we're looking at this, we have several different options that we can use for our patient who is saying, hey, I can't take these pills by mouth. So I need you to give me another route, right? So I have my pantoprazole that I could have given them, right? I have an IV option to give those patients. So this is some of the things that you're looking at when you're thinking about this. And that was that chart that we had that was telling you like, hey, here are different options that you have to give your patient this medication, okay? This was just a little meeting for me to see y'all smiling faces today in class, but you're not here, so there's that. So you're going to have where you're going to see several different options when you're looking at some of these things. Make sure that you're going through and saying, hey, is there something that says I can't use this? Is this one of those omeprazole and lansoprazole that has a lot of inhibitors? And if I tell you that this person is on a med and I'm worried about them having some CYP interactions, this is why we would be looking at things like this, okay? So just, Steve Harvey. So just make sure you're paying attention to that, okay? Oh my gosh. Looking at this next check on learning that we have, 44-year-old male came to the clinic. He has GERD and he wants an agent that will be long lasting, so more than 24 hours. He has hypertension, he has diabetes, he's taking some other medications. Which of the following is the most appropriate recommendation for our patient? I don't see any typing. Mm-hmm. Oh my gosh, y'all are just being crazy now. I know. So y'all are gonna get in trouble for this behavior. Just kidding. Chat's going crazy. Okay, so when we're looking at this, right, some of the key words that I want you to pay attention to. I want something that is long acting, right? I don't want to take this medication often. I'm trying to say, hey, give me something to where I'm not frequently taking my medication. The only ones that we talked about that had that benefit were our proton pump inhibitors. When we were looking at our H2RAs, we had to sometimes take those more frequently, several times a day that we were taking these medications. So again, just make sure that you're paying attention to, all right, what are the benefits? What precludes me from giving one of these over the other? And you'll do very, very well in this section, okay? So just making sure, hey, what are the key words? All right. Now, moving on to our peptic ulcer disease. You had a question? Oh, I didn't tell y'all the answer? Did I say the answer? I don't remember. So our answer was omeprazole because it's a longer acting one, right? So like I'm hanging in there for a longer period of time, so I use a proton pump inhibitor. Your calcium carbonate is just an antacid, so I'm not going to be using that one like that because that's like my on the spot. My misoprostol, this was the one that I told you we don't use as often. And then your famotidine is your H2RA, which sometimes you'll have to take more frequently. All right. Peptic ulcer disease. So when we're looking at peptic ulcer disease, and you'll learn more about all of these diseases, this is one where we're trying to say, hey, let me check and see if this patient has H. pylori. If they have H. pylori, then we are going to make sure that we treat our patient. So in our GERD patient, we weren't really worried about H. pylori, but if I have somebody who is presenting as if they have peptic ulcer disease, I may need to treat them for H. pylori. So with that treatment, we have two different ways that we can go about this, which is we kind of lightly touched on it when we were looking at our antibiotics. So you have your triple therapy and you have a quadruple therapy. When you're looking at your triple therapy, we have our PPI and our amoxicillin or metronidazole. Most of the time you'll see amoxicillin used, and then you have your clarithromycin. So that's 3 drugs, right? One or the other, amoxicillin or metronidazole. You're not going to use them both, okay? And you see that they're on this medication for a minute, and I want you to remember that. So 10 to 14 days, depending on how some people react to the medication. Some people will have to be treated several times for H. pylori, okay? So just make sure that you're looking at the duration as well. Considering your quadruple therapy, this is more so for your patients who are, we're worried if they have a penicillin allergy, right? So that's why you don't see that amoxicillin added. And then because I put them on that metronidazole, I got rid of my amoxicillin. You see that's when I'm adding my bismuth or my Pepto-Bismol to that with the tetracycline. Your PPI is always on board. Duration, still the same. And then you see again, if I had my patient, typically when we say previously, we're talking about within the last 30 days of some other type of antibiotic use, where we'll try to say, hey, okay, I'm going to put them on this. So this is like your triple therapy is usually your first option, and then your what happened? And then your quadruple therapy is typically going to be what you do second, okay? There are little caveats, but I just want you to remember it in that simple way. Looking at your confirmation of eradication, you're just going to retest them again, essentially. So I just want you to make sure that you're understanding that once you try to retest them, they need to be off of that proton pump inhibitor for at least a week or 2 before you're retesting them, okay? If the treatment didn't work, then you will put them on, and you started with triple therapy, which is typically what you're going to start with. Then you will move them down to the quadruple therapy. If that fails, then you start getting labs to try to say, like, why is my drug not working? Why is my medication regimen not working? Let me get through this little section and then we'll do our break. So our H. pylori ulcers that we have. So because of the disease, what will happen is that they can sometimes cause ulcers. So what we can do is we have on our drug regimen. So these are all of the different things that we talked about, some of which you've seen before. So I'm not going to go over these all again. But you have your PPI, your clarithromycin with your amoxicillin, your clarithromycin, making sure that you're understanding that that's one of your drugs of choice as well. We just this is in our first line. So our PPI, clarithromycin, and amoxicillin, these are a part of that first one that we talked about, right? Like our first one that we want to do. When you see the bismuth subsalicylate, the tetracycline, and that metronidazole, they will be added on to that proton pump inhibitor, but these are usually the ones that we'll use second. Sorry, this writing looks horrible, okay? So again, just look at the summary of the big adverse effects that are on here. Mechanism of action are the same things that you've already seen before, so nothing new on this slide. Looking at our NSAID-induced ulcers. So remember I told you a patient could be on an NSAID and they could, especially if they're on them for a long period of time, because sometimes we will do that with pain management, what you can see is that they can have ulcers that end up forming. Also, if you have patients who are in the ICU, they're in a lot of pain. So you'll see sometimes that we have them on certain medications, and those will cause those stress ulcers. So we will prophylactically put them on our medications to kind of decrease that the disturbance to that gastric lining that they have. So when we look at NSAID-induced ulcers, they're caused because we have now irritated that epithelium enough with our NSAID, and it's not producing the prostaglandins because our NSAIDs are stopping prostaglandin synthesis, and that's what we said protects me. So if I have now stopped that production, I am losing my GI protection, and therefore you can see those ulcers start to happen. So looking at our risk factors, not going to ask you about that. The one that I want you to know is this NSAID therapy, right? If I am taking NSAIDs, I am likely to get an NSAID-induced ulcer. okay? We'll see this with some of our other meds, but I just want you to remember our NSAIDs for now because that's one of the biggest ones. When we're looking at our therapy for our NSAID ulcer, when you see the way that to read this chart, so if they have a low cardiovascular risk, right, that's saying like I'm not worried about any cardiovascular concerns with my patient. They have a good heart. We're good to go. Then I have my low GI risk, okay? So if I'm looking at this, I'm saying, hey, there's nothing that makes me think that this person is predisposed to having any of those risk factors. So that where it says no RF, says no risk factors. So I will tell you how many risk factors your patient will have, okay? If you have a question on something like this. So if I'm low GI risk, low CV risk, just give me my NSAID. I'm good to go. I'm not worried about it. If I'm low CV risk and I have a moderate GI risk, okay, so you are worried, I have 1 to 2 of these risk factors. Again, I will tell you how many. Then you're going to try to protect me. You're going to say, you know what, Raina, you need some kind of protection. So I'm going to give you a proton pump inhibitor, or you'll see that misoprostol that can also be used. But it's one or the other. If I am high risk, meaning I have more than 2 of these things going on, right? I have more than 2 of these risk factors. I'm falling apart. I'm on an anticoagulant. I'm 70 years old, and I've had peptic ulcer disease before, and I take aspirin every day, right? So I'm low risk cardiovascular-wise, but I have a high GI risk. I have a high burden on my belly, right? So I can either try to avoid giving this person an NSAID altogether, or I will give what is called celecoxib, and we'll talk more about this, but it's more selective for COX-2, so therefore you're not going to see as much of that GI, the bleeds and things that we would typically see. So that's why you see the celecoxib specifically listed as the NSAID that you would use, and I would still protect them the same way with that PPI or the misoprostol. Now, your high CV risk, you're just going to go through and read the chart the same way. So if I have a high CV risk, right, I'm taking low-dose aspirin every day because I had some type of cardiovascular event, whether that was a stroke, heart attack, something you'll see sometimes we'll throw aspirin on for them. So I'm going to try to keep them with naproxen as their NSAID, and I'm protecting them no matter what their risk factors are. Now, if I am high in both categories, high CV, high GI, don't give me an NSAID, okay? We'll try to use something else like Tylenol to help that person with their pain. Or we might go to sometimes like a pain medication for them depending on the severity, okay? So if I'm high in both, this is your only block where you see where we are not trying to protect them from an NSAID. We're saying no NSAID, okay? And that COX-1, COX-2, that's just telling you about the likelihood of bleeding on there. We'll get more into that next semester. So just understand that it's something that we're going to talk about a little bit more. And then again, this stress ulcer, just understanding that we can prophylactically treat our patient. So all I wanted you to remember was what we talked about before. You have a H2RA and we have a proton pump inhibitor that we can use, okay? So those are our 2 options that we have for our patients, H2RA or a proton pump inhibitor. Let's go ahead and take our 10, and I'm going to leave this recording going because sometimes when I stop it, it doesn't work. Oh, let me try. So you want to pause. Okay, guys. Okay. When we're looking at our nausea and vomiting, we're going to talk about this again next semester, so kind of keep these medications in mind. Some of these you have seen before, and some of them you've heard about, okay? So when we're looking at this, we have several different medications. This is going to be just, oh, is it still there? This is just going to be your summary slide giving you all of the different drug classes that we have for different types of nausea and vomiting. So you have general medication, so just general nausea and vomiting that somebody could have. chemo and radiation therapy. So sometimes when someone is going in for chemo, they will experience nausea and vomiting most of the time. And so we will pre-treat them, or we can give them medications after or during their chemo post-operatively. So like if somebody has a procedure and they end up vomiting or they get nauseous after their anesthesia, and then you have your motion sickness, your vestibular nausea, pregnancy, we'll go through that whole algorithm next semester, and then your gastroparesis medications that we can use. So as you see, several different options that you have that you can use to treat things. And when we're looking at our ginger, we do have tablets that we can use to treat ginger with. So depending on how you say it is a medication, I mean, we're using it to medicate that person and hopefully prevent them from proceeding to vomiting. So in a way, I guess you could say yes for this. All right, looking at our different options that we have. So we've seen this already. Same exact slide. You have your scopolamine. We can use this for surgery. We can use this if I'm going on a boat, okay? If I went and had a surgery so I can go on the boat, all right? Remember, this was the patch. We're putting it behind the ear, making sure that we understand that it has those anticholinergic effects that can be seen and that they need to wash their hands. Doubling the patch is not making anything more effective for that patient. It is increasing their adverse effects, okay? And it makes people feel very, very sick, and they are not happy on their cruise. They actually ruin it, okay? Looking at our next slide that we have available, these are our antihistamines. And again, you're going to see this next semester, so kind of try to make yourself a little familiar with it. When we look at our first generation antihistamines, we have meclizine, diphenhydramine, which a lot of you probably know, Benadryl, dimenhydrinate, doxalamine, and then your doxalamine, which are pyridoxine, which is going to be called diclegis, depending on what the formulary looks like at the time. We specifically use that diclegis for our pregnant women who have very severe nausea and vomiting that doesn't respond to like our ginger and all of our other medications that we'll have, like some of the antihistamines and the promethazine. You'll sometimes see where we try to get that diclegis. And if you can't get the one that is combined in the one pill, you can just prescribe them the doxalamine and the pyridoxine and have them take them together. Mechanism of action, antihistamine, right? So if I'm I'm blocking antihistamine, so I'm blocking histamine, okay? So therefore, I can decrease the amount of vomiting and motion sickness that my patient feels. I fixed it, okay? Make sure that you also understand, and I want to delineate these two words. When you're talking about nausea, that's just like that feeling, right? Like you feel like you're about to vomit. Not the same exact thing as vomiting. Some people will have nausea and never proceed to vomit, okay? So just make sure that you're understanding the difference between those two. Looking at our antihistamines, a lot of them cause drowsiness, and a lot of these will have anticholinergic effects. So make sure that you remember that those are us drying something up, okay? So I'm going to give this about 30 minutes to an hour before I do whatever that event is that I think that I'm going to potentially experience that antihistamine, that nausea and vomiting. But make sure that you just understand, hey, I am worried about the drowsiness that patient may feel. All right, hot topic. I'm just kidding. So our cannabinoids, we have medications that are in the pharmacy. They come in capsule formation, and you have dronabinol, which we typically will store in the refrigerator, nabilone, and cannabidiol. Okay, the one that we use the most is your dronabinol. These are controlled medications, go figure, right? So we're talking about cannabis. We're talking about trying to help with the nausea and vomiting that some people feel. Also, we see that this can help with the appetite and help stimulate the appetite because it's hitting those cannabinoid receptors. So I have decreased vomiting, increased appetite. We use this a lot in our chemo-induced nausea and vomiting patients. This also will help some of our patients who have issues with wanting to eat after they had chemo. They sometimes will have a suppressed appetite. So So this is kind of hitting that 2-in-1 for most of our patients who have cancer. Anorexia, anorexia just in general, not just in our patients who are AIDS patients, but we will see that a lot of those patients are going to be needing some type of stimulant. And then you see we can sometimes use this in our seizure patients, which we'll talk about a little bit this block, I believe, as well. Our interactions, just making sure that they're not smoking regular weed while they're taking our cannabinoids, because any type of medication like that, any type of recreational drug that can have any type of psychiatric involvement, so even like mushrooms, people who can be drinking alcohol, different things can interact with these medications, which makes sense. And then looking at your appetite increasing, euphoria, cognitive impairment, these are the things that we are trying to use the medication for, okay? So when you're looking at that, just make sure that you're paying attention to this. Now, if you end up prescribing this to one of our patients who is active duty, they will have a prescription for it. This is a synthetic THC. It will come up. So make sure that you are telling your patients that they must have an active prescription. I tell patients, if I gave you 30 and you're out and it's been 30 days, even if you're not out, come back and see me, because there are lots of times where people will have extra and they will use extra and it's months later. And then you pop hot on a UA and it's like, well, the clinical indication for you using that medication was gone. And that's for any of, I tell my patients that for any of our pain meds, I tell them to watch out for that. Even some of our stimulants, the same exact thing. And most of the time for this, again, it has to be pretty bad. I see that question here. It has to be pretty bad. A lot of the times too, when we use this, it's kind of us getting that 2-in-1 for that chemo-induced nausea. So for my cancer patient, because I can also have that added benefit of, hey, let me help you eat. Okay, so that's kind of where, I guess, to answer your question, that's where you can kind of see it as a drug of choice, but not necessarily, because there's so many other things that go into it. And TRICARE will approve this. This is on our formulary. Dronabinol was probably one of the first ones that was on our formulary. So yes, with that clinical indication, they will. All right. Our serotonin or 5-HT3 receptor antagonist. So again, the name is telling you what they're doing, right? I'm blocking that 5-HT, which is serotonin. I'm blocking those serotonin receptors in the gut and in that CTZ or your chemoreceptor trigger zone, which is what we think induces a patient feeling nauseous or wanting to vomit. So if I can block those areas, I am succeeding, I'm winning. So you see that your serotonin receptor antagonists all end in cetron, okay? Ondansetron, ganacetrin, dolasetrin, and your palonosetrin. The one that we typically will see used a lot is going to be your Zofran. You also have an ODT formulation available, which disintegrates in their mouth, which is very good for your patients if they're actively vomiting and they're not just nauseous, right? Because if I swallow something, I'm likely to vomit it back up, versus if I have the oral ODT under my tongue that is going through the mucosa that way, I'm going to still be able to systemically absorb it. So that is a great benefit in why a lot of our patients and a lot of our prescribers like to use that Zofran. Looking at your palonosetrin, just how I try to tell you guys, think about this is like he's been my pal for a long time. So because I'm bound, I'm in that relationship for a really long time. We got a long half-life. We're strong. We're going to make it, okay? We don't use this one typically orally a lot. For the most part, our Zofran is typically where we're going. Clinical uses, just general nausea, vomiting, post-operative chemo, very good medication. Radiation, which is similar to our chemo, same thing. Adverse effects, very well tolerated. Big thing that I want you to make sure here is that QT prolongation, more so with your dolasetron, okay? So QT prolongation, big deal. If I have issues already with my heart, you don't want to make it worse. Looking at our phenothiazines, when we're looking at these, we have oral, we have rectal, okay? And I have IV. If I'm vomiting, oral may not be a great option for me. So having that rectal option comes into play here. Can y'all still hear me? So they're saying my connection is stopped. Okay, sorry. So when we look at our products that we have available, that for our phenothiazines, our rectal formulation is very good if someone is actively vomiting, okay? So you have your prochlorperazine and your promethazine. A lot of the times we will use our promethazine. You see that we're using both of these for nausea, vomiting, but with that promethazine, I also get the benefit of that motion sickness. I also have an IM formulation that I can use when I'm looking at my promethazine, okay? If you are going to use this IV, which the promethazine, we do use IV tip a lot in inpatient setting. Make sure that there is slowly being infused, and sometimes we'll inject it, but it needs to be diluted, because if you don't dilute this, then you can have tissue necrosis where that tissue where you did your injection will die. We don't want that to happen. So don't make it like a quick slam and push whenever you're doing that injection, okay? You're making sure that you're doing it, and if you're slowly, and if you're doing it in the IV, again, that should also be ran slowly as well. Again, looking at our mechanism of action, what we're doing is we're blocking that, it's working in the CTZ, right, which is where we said we had nausea and vomiting. So if we're looking at that, I'm blocking the dopamine, I'm blocking muscarinic and histamine receptors. So I'm just trying to take care of everything, all right? Sometimes after people take these medications, they will feel kind of groggy and like in a fog because they do cause drowsiness. And then your general use, just nausea, vomiting. And then if you have chemo-induced, we can treat our patients with these. Adverse effects, just make sure that you're understanding that we have several EPS or extrapyramidal symptoms that can be experienced. So we're talking about like movement things. You have that hypotension and the drowsiness. So just think about EPS and drowsiness for the most part when we're looking at our phenothiazine. Okay, looking at our metoclopramide, this is a benzamide. When we're looking at this POIV intranate, we have several different options for this. Great medication. We definitely use this a lot inpatient. What you see here is it's increasing the acetylcholine response, and therefore I'm going to see that I can increase in acetylcholine response and can increase GI motility. And then you can see you have some blockage of that serotonin and dopamine. So therefore I can get the increased GI motility, and then I can decrease the nausea and vomiting that some people are going to be experiencing, okay? So again, working in that CTZ like our other medications that we talked about. Clinical uses, if you have a patient who has chemo-induced or just regular nausea and vomiting, and then also you can see that your patients who have GERD, if they actually are experiencing that nausea and vomiting as a result of the GERD, we have the Reglan that we will give them PO for them to take home. Your diabetic gastroparesis is essentially like them having that slowed down GI tract just from the fact that they are a diabetic patient. And so I can increase that GI tract motility with this medication. I can get things moving for that patient. Adverse effects, drowsiness, restlessness. So think about those CNS effects again, like we have so far, and then those EPS symptoms coming back again, okay? Because I'm looking at that dopamine activity. Anytime you see dopamine, think about EPS symptoms. All right, your other medications that we have, your trimethylbenzamide, and we have amisulpride. So when you're looking at your trimethylbenzamide, this one, 2 different formulations, oral and IM, which is, again, good for our patients if they are actually vomiting. When we look at your mechanism of action, again, I'm telling you that we have some dopamine antagonistic properties there. I have anticholinergic, so I'm drying things up, antihistamine, so I'm thinking about drowsiness as being an issue because it's all of these things. And then I'm decreasing that feeling that that patient is going to feel in their CTZ. So therefore, I am decreasing that impulse. My uses that I have available, you see that apomorphine. What apomorphine does, so for apomorphine pre-treatment in Parkinson's patient, we're going to talk about this drug a little bit later, but it helps with muscle movement loss. And so one of the big side effects is that a patient can have a lot of nausea and vomiting. So that's why we will pre-treat them with this medication to kind of help them reduce some of the symptoms that they're going to have from that. You see that I can use it for nausea and vomiting after surgeries, or if I'm talking about any illness, gastroenteritis, and some of the times if they're nauseous from that, depends on how long they've been nauseous. Sometimes we may or may not give them meds. Looking at your adverse effects, we kind of talked about them. So diarrhea, blurred vision, drowsiness, basic kind of things. If you think about your mechanism, you can kind of pull some of that out, and you'll also have some issues with some of that movement. So anticholinergic properties. Looking at your amisulpride, this is an IV medication. So for the most part, we're going to be using this inpatient. But when we're looking at our nausea and vomiting, we see this typically used more so as an antipsychotic medication, but it still does work in the CTZ. So that's why we see some benefits that are used here for our post-operative nausea and vomiting patients. Adverse effect, we're worried about that QT prolongation, the hypokalemia, hypotension, okay, so low blood pressure, low levels of potassium, and then this elevated prolactin can be an issue for some women sometimes, but it depends on what's going on, but just understand that the prolactin levels can change, and we'll talk about that more when we start talking about some of our other disease states like Parkinson's. So antagonistic to our D2 and D3 receptors, here you see that we don't have a lot of affinity for those serotonin receptors, so it's not as much. And then, yes, intranasal for that IN question. All right, this is a slide that is talking to us about our neurokinin 1 or NK1 receptor antagonists. So these are all of the different drugs that we have available. For the most part, I want you to just look at the specific MOAs that we have over here. Make sure that you understand that these are good whenever we're using these with our 5-H3 antagonists, but you can see them used sometimes by themselves. But a lot of the time, we're going to use these in conjunction with. You also see that we have dexamethasone that can be added. This is a steroid that we'll talk about. Those sometimes help decrease the nausea and vomiting as well. So for the most part, when we're looking at these, you're looking at your chemo-induced type of situations, okay? So just, I think for your use and what would be easy for you to kind of remember it is to put like chemo-induced nausea and vomiting, especially for your fosaprepitant, your nutilopatent, and your rolapatent. All of these are your ones that are definitely for your chemo-induced nausea and vomiting. But you see that also with your amends, this is for, you're going to have some chemo medications that are very, very potent. And this is the one that we typically use a lot, but it depends on how sick that patient is. And you see that we have this one kind of used prophylactically when we're talking about our amends, okay? So all of these are used for your chemotherapy, and then best for us to give these with one of our 5-HT3 antagonists in that dexamethasone. We see a lot of interactions here, right? So just remember SIPs. We're thinking about interactions. You can experience, and by way of cancer itself, you'll see that they can have a loss of appetite. This can mess with their bowel movements, whether it's constipation or diarrhea. And then a strange one here is that they can have hiccups. So remember, with the ending of this, all of these are potent, okay? So your NK1s are potent. They all end in potent. Okay, corticosteroids. We are going to get a heavy dose when we're talking about corticosteroids next semester. So for right now, what I want you to understand is we have dexamethasone and we have our methylprednisolone. When we're looking at our dexamethasone, you have two different ways in which you can give it. You have oral options, you have IV options. There are several different ways for us to give our dexamethasone, but when we're looking at our methylprednisolone, you see that you have an IV formulation, which is very good for some of our patients, especially if they're doing their chemo and they're highly emetic or where they're going to be vomiting, okay? Looking at our mechanism of action, not very well understood, but we do know that our corticosteroids help with inflammation. So we're getting those anti-inflammatory responses, but how it directly connects to decreasing the nausea and vomiting, we are not sure. Looking at your clinical use, you see again that chemo-induced nausea. This was on that chart that we previously saw where we said that you would use your NK1 with the dexamethasone, or you would use your 5-H3. So this is just, again, reinforcing that. Also understand that there can be a lot of mood changes. You can see where some people get like a boost in their energy and some people it's like a downer. A lot of people will tell you almost immediately when they start taking the corticosteroid, like, oh, I'm having insomnia, like I can't sleep very well, if they're very sensitive to it. So you'll see that sometimes we have like these paradoxical types of adverse effects when we're looking at some of the adverse effects. So like, hey, I can increase your energy, which means that you're going to have insomnia, right? But I can also make it to where you have mood disturbances and you're kind of like I'm just out of it. Like I don't want to deal with anything. Same thing with, I see the question here about diarrhea and constipation. These are not so when we talk about contraindications are like a drug having a contraindication with another drug or a disease state. These are two different outcomes that a person could potentially have whenever they are taking the medication. So it just depends on how that patient has responded to the medication. And again, when we're doing those trials, remember, I can have a bunch of people who had diarrhea and I can have a bunch of people who had constipation, and now I'm putting both of them in that as an adverse effect. So the mechanism in which that is happening, there could be several things as to why that has happened to a person and why they responded to the medication that way. So just understand that they're just two different things as far as like what can happen. So that's why I just try to put it in a bow and say like they could just have issues with them using the restroom because it could go either way. Looking at our next drug class, you have your butyrophenones. So when we're looking at this, you have droperidol. It's an IV medication. So again, this is something that you're going to be seeing in an inpatient setting. What it does is it blocks the dopamine and the CTZ just like we had our benzamides do. And so therefore, you're likely to see that decrease in the nausea and vomiting. So post-operatively, you can use it. You see that we don't use it anymore for the antipsychotic effects. So just, again, making sure that you're realizing post-operative nausea and vomiting. We can also use this for very minor procedures if we were trying to sedate someone with a benzo. So we would use this to kind of just knock them out, so to speak. And the reason why we're being able to use it for that is because I can have drowsiness as an adverse effect. So looking at our adverse effects here, you see that we have those EPS symptoms because, again, we're working on that dopamine. So that's why you see that. And then look at your QT prolongation. So if somebody already has a prolonged QT, I'm not going to use a medication that's going to further prolong their QT. The other drug for you to remember with your QT is going to be your serotonin. So remember our 5-HT3s, those were the ones that we were talking about that could also, we were worried about our QT prolongation. All right, benzodiazepines are what you will hear people call benzos. So when we're looking at our nausea, vomiting, we have lorazepam and diazepam. These are very highly addictive medications, so we don't try to prescribe them if we don't have to. So what you'll see is that they all end in PAM. Our mechanism of action is that they're increasing GABA activity. So essentially what that means is that it is going to decrease our anxiety. It's going to sedate our patient. It's going to decrease the amount of reflexes that they're having. When you're looking at our clinical use, again, you see that these are going to be used prophylactically for your patients who could be so nervous about their chemo. Let's imagine it being like their very first chemo session. They don't know how they're going to respond to that medication. And then they are going to, we kind of are doing a 2-in-1 when we're using this benzo. Because they have so much anxiety, you can work yourself up to where you do vomit. So in these patients, that's essentially what we're doing. Some patients will do this every single time they have their chemo. They're so anxious about the after effects, how they feel after the chemo. And some of them have been on chemo for a while and they still experience this, and we will still sometimes treat our patients, okay? Looking at our adverse effects, drowsiness, confusion. These are controlled medications. I know it's not listed on there, but these are controlled medications, so making sure that you're understanding that addiction is also a possibility here, and that seizure-like activity that can occur in our patients. So quick check on learning. 23-year-old active service member came and she's complaining of motion sickness every time she goes out to the field on her tactical vehicle. What drug option would be the best choice for our patient? So when we're looking at this, oh, I didn't know it lets you do a poll. Y'all, you see the poll? I didn't see that. So when we're looking at this, she's active. She is on the move, right? She is trying to get something specifically for motion sickness. So this is us looking at those things that are saying, hey, if I am dealing with motion sickness, because we had several that dealt with nausea and vomiting. We didn't have a lot that dealt with our motion sickness. So I can have her stick on her patch before she gets onto her vehicle, right? Definitely C. She's gonna be in the field tripping. She cannot have C, okay? But we would give her I cannot. This is why the chat was closed. We're going to make sure that we're letting her still be present, right? She needs to be present in participating. Another medication that we could have had besides our scopolamine, so our answer is A, but another option that we could have done was like one of our first gen antihistamines, but the issue with that is that we could potentially cause a lot of drowsiness, right? So just paying attention to what your person has to do, like what are their activities, what are their jobs, because even if we get her, we still have to get her to the field and she has to participate, okay, even if she's not the one who's driving. All right. Next time we'll try the poll thing if it comes up. Okay, diarrhea. So you will have patients who are going to come in. They're going to tell you about diarrhea, how their stomach is not feeling well, how they have nausea and vomiting, right? Sometimes we will see this, and sometimes we won't see them actively vomiting or using the restroom while they're in your presence. And you will be very fortunate for that. But we have several different options. This one, I do want you to look at the dosing and remember the dosing for this medication. So our anti-motility agent that we have is going to be loperamide. People are allowed to buy Imodium over the counter. What it is doing is a mu opioid agonist, and it's decreasing the peristalsis or the movement. So therefore, now I can absorb more of that water out of the GI tract for them to actually form their stool. Okay. I'm also seeing less of that acetylcholine release, and so therefore, ultimately, I am slowing down how much they're going to the bathroom. Big thing with this is that you see that meperidine derivative that's also in there. What that is saying is that this medication, meperidine, is used for pain. So this medication does have a meperidine moiety to it. Making sure that you're also understanding that they're not going to have any pain relief from them going to the bathroom, but what it will help them do is stop going to the bathroom. You can still abuse this medication, okay? And again, because it's over the counter and they don't need us for it, it's not a controlled medication. It does have a high abuse potential because of that meperidine. The meperidine is what they can sometimes get addicted to, okay? Looking at your clinical use, so non-invasive diarrhea. So essentially we're trying to say, hey, I want to help this person decrease the amount of times that they're going to the restroom, okay? Usually first line, but not something that we're using for it's first line for our acute situations. What I do clinically is sometimes I won't immediately stop the person from going to the restroom. I wait a couple of days because we want them to get the bad stuff out, right? So I don't immediately stop diarrhea depending on why they have presented that way. So that's why you see if they don't have colitis or it says non-invasive, okay? So understanding the source of it and understanding how long. Somebody came to me and they said, oh, I've been going to the bathroom for 5 days and it's been diarrhea. I am worried because now I'm worried about dehydration. I'm worried about, yes, here's some loperamide, okay? But if they, it was the first day, I might tell them to just go ahead and try to get all of the bugs out, because that's what they're going to come out to. Adverse effects, they take too many, they're going to have constipation. So essentially what you see is that they're going to take 2 tablets or 4 milligrams after that first loose bowel movement that they have. And then after that, they'll wait until they go to the bathroom again. They go to a bathroom again, they'll take another tablet. They go to the bathroom again, they'll take another tablet. And they continue to do that until it stops, okay? So they essentially are loading themselves with 4 milligrams, which is 2 tablets. And then they only take one again if they have another loose movement, okay? So they're treating to the response of the medication. All right, it skipped. Diphenoxylate and atropine, Lamodal. This is a control medication that we have. Essentially, looking at that atropine and what it does, because we talked about that, is it's stopping the acetylcholine release, and it also is a part of this medication to try to help discourage somebody from abusing this medication due to the diphenoxylate portion. So this is a mu opioid agonist, and when we talk about this, you'll see that when we talk about pain, this is something that is very important. So that is why this medication is controlled, but we are trying to combat the addiction portion of it with the atropine. So making sure that you're paying attention to that meperidine derivative again, okay? You have the meperidine derivative, and then if you give them enough of this Lamodal, you will see pain benefits or that opioid benefits, okay? So that's why we're worried about it for the abuse, and we say, no abuse, I'm going to give you the atropine portion of it. So this comes together. Clinical use, looking at this, you have that diarrhea, refractory diarrhea. They're not responding to that loperamide or any of the bismuth that we've given them. So just make sure that you're saying, hey, I am trying to give this as a short-term thing. I am not going to give this to my young kids because there's a potential for them to be abused and it needs to be to get addicted to it. And we are making sure that it's non-invasive as to why we're treating. Adverse effects, basic things that you see here, as well as that dry mouth and those anticholinergic effects, right? Looking at our bismuth subsalicylate, our Pepto-Bismol, we've talked about this several times. So again, antimicrobial, anti-inflammatory effects, again, same things that we already saw, okay? The dark tongue, stool, all those things. Octreotide, this medication is used a lot inpatient. So what this is doing is it's stopping growth hormone. We're going to talk about that a little bit as well. But when we're looking at this, we're trying to say, hey, if there is some type of reason or some type of tumor that is causing someone to have diarrhea, or if they are HIV patient and that is why they're having diarrhea, that is when you will see us using octreotide. Okay, if you use too much of it, you can see that constipation. Very worried in my patients who have diabetes because I can see hyperglycemia occur in those patients, okay? Uh-oh, what did I just do? This change, right? Teglutide, I'm going to answer when we're done. I'm going to try to get us through these. Teglutide, so when you're looking at these, making sure that you're understanding sub-Q medication, looking at it again, GLP, we'll talk about this. This is an analog, so essentially what we're trying to do is inhibit gastric acid from being secreted. Good for your patients who have short bowel syndrome, adverse effects, stomach pain, and because they're injecting themselves, they're going to have injection site reactions. Lactase enzyme, or this is your lactate, this is going to help our patient break down lactase so that they don't have a lot of the symptoms that they have from being lactose intolerant, so like the diarrhea. So it helps them be able to eat certain things. And then your probiotics, sometimes we will prescribe these with some of our antibiotics to kind of help put back the good bacteria. So it helps inhibit like your bad growth and tries to reestablish the normal flora that are supposed to be in there. You can take probiotics every day. They are available over the counter. We're thinking that it can help increase the immune response, but again, because it's over the counter, kind of hit or miss. Looking at our clinical use, preventing that antibiotic-associated diarrhea, and for some of your patients who have C. diff, we will put them back on this medication. So let's use, oh, no, I didn't want to pop up. So looking at our check on learning. this, I'll just give you the answers to them. So first line for acute diarrhea, we had our Imodium, our mu opioid agonist. We had the Imodium that was there as well. Component that we were going to discourage abuse with that atropine. So you have your Lomotil, controlled substance. You also had your Lomotil, and then which one causes less drowsiness would be your Imodium. All right, let's move on to our constipation. So when we're looking at constipation, we have several different options. We have our non-Pharm, where we're going to tell them, hey, have some fiber. We do have fiber in the pharmacy. If you order it, that does depend on the formulary at the time. Looking at our treatment that we have available, so you have several different types of laxatives that you can use. So you have your bulk-forming laxatives, your emollients, your osmotic laxatives, stimulant laxative, lubricant laxatives, and then our other medications that we use in certain situations depending on what has caused the constipation in our patient. So looking at our bulk forming laxatives, essentially they're saying what they're trying to do. So they're trying to bulk up so that somebody is able to kind of use the restroom. So they're retaining water and increasing the peristalsis. So the person has to drink water when they're taking these medications. If you don't, they don't work. They just make you feel a lot more bloated. So you see the different kinds that we have. So your Facilium is your Metamucil. You're going to make sure that you mix it and they have to drink it within 10 minutes. Your Benefiber, again, just make sure that you understand that it is, even though it says wheat dextrin, it is considered gluten-free. But if somebody has celiac disease, they should not be using this medication. Your synthetics that we have are listed there. You also see some of your other ones that are listed down at the bottom for the most part. We don't see pectin and things used as much, but you can. These are just kind of home remedy things for patients. Already told you your mechanism of action. So again, the big thing here, counseling point, is that they need to drink water. Make sure that you understand what falls under a bulk forming laxative and what it is doing. First line medication for us to try to treat that constipation, and we do tell some of our patients to stay on this every day, especially if they have IBS, constipation, things like that. We do tell them to continue to use these. They're very, very safe. Onset, you see that it takes a while, 12 to 72 hours, adverse effects, gas and bloating that you're going to see. So looking at this with your interactions, again, these are some important medications that you'll see. So the tetracyclines, your anticoagulant, warfarin. Warfarin has popped up on so many of these medications that we've had. So just make sure that you're understanding that we have several interactions that could occur. If somebody has an obstruction, and meaning like some type of GI obstruction, doesn't matter if we can try to, there's several different drugs that we would use to try to get them moving, okay? This is not one of them. Also, our diabetic patients, this will make them have their sugars go out of whack, is kind of how we'll say it. So their glucose levels will no longer be managed sometimes because of the sugars and the calories that are in our bulk forming agent. Looking at our emollients, these are our stool softeners, okay? So they're making things a lot softer. We give these a lot to our pregnant women after they, or anybody really who's had a surgery, especially if it's abdominal and we're worried about them using the restroom to push. These are gonna help soften their stool, okay? So essentially these are those surfactants that are gonna use some of that water and the lipids to kind of help make their stool softer so they can use the restroom. Our use, prevention of OIC or opioid-induced constipation, and we'll also use Senna. And again, like I told you, that clinical use to help somebody not strain. But you can, again, see these in our patients prophylactically because they do take a while to work. So sometimes if we're going to give a pain med to our patients because we know that those can cause constipation, we'll have this on board. So we'll tell them we're trying to mush and push, okay? So these kind of help soften everything for them. See that delayed onset, which sometimes that opioid-induced constipation also takes some time. So you can see that we are trying to prophylactically treat them, get ahead of it. Diarrhea is going the opposite way, right? Again, with like we talked about so far in this class, drinking lots of water, and then some people saying that the taste is not fantastic. Mineral oil, we are going to try to not do that. Some people still do use mineral oil. It's kind of like an older thing that we used to do back in the day, but people still do use mineral oil, so make sure that they're not using them together. And then, how many do we have left? Okay, let's do this one really quick. So your osmotic laxative that you have, so when we're looking at this is a saline type laxative. You see that it has several different formulations that are available. So you have your magnesium, citrate, hydroxide, sulfate, and phosphate. Depending on what you are trying to treat, we can use several different formulations, making sure that you're looking at your patient as well. These are also different ways to take them. So this is a bottle that they drink. You see these go on and off the market, super effective. Your milk magnesia, that's that thick white. So if somebody just wants to hurry up and get it over with, a lot of times they like the citrate. When you're looking at your sulfate, this is typically what people are using to like soak in, right, after they have a huge workout. And then your fleet, this is going to be like an enema that is stuck up the rectum, and then you squeeze the bottle. Depending on how constipated they are, if they are impacted, they will not be able to put that applicator tip in. And if they feel any resistance whenever they're initially putting that in, they need to stop, okay? Your mechanism of action, again, helping get some of that water into the bowel to help them go ahead and pass their stool a lot easier. You do see that you'll have sometimes where patients will immediately feel like they have to go to the restroom, like you can't hold it because it's drawn in so much of that fluid. So when they use the restroom, it is very much so going to be very liquidy, okay? And they need to be by a restroom whenever they take this medication. Don't take this medication and go out. Don't prep for your colonoscopy and taking these medications and going out. They need to be by a restroom. Onset, very, very rapidly, okay? Very quickly, but you can see that some of your patients may not respond to it and they have to take higher doses. With those higher doses, you are likely to see that electrolyte imbalance, and then when they do get that response, it may be very dramatic. I do tell my patients, when you start to see like yellow mucus coming out from using these, to stop. Some people will continue to drink them, especially when they're doing bowel prep, but that means that you've cleaned out all of the stool and it'll kind of come out yellowy and it looks like thick mucus, kind of. That is where you can tell them, hey, like, you don't need to take anymore. Caution in our patients with our renal insufficiency, because that magnesium can build up and cause toxicity, and then they should be taking it on an empty stomach, making sure that they're drinking a lot of water with a lot of these meds. And yes, some people do use their magnesium for that. And they might go poop while they're trying to do height and weight. I'm just kidding. But yes, people do prep and try to do weight loss with this. We do not recommend this for patients because there are several different underlying conditions that they can have. It's also not super comfortable, but you will hear a lot of people using laxatives for things that are not in this clinical use. They're prepping their bowels for just because they want them to be clean. Some people do interesting things. And then the 16 max dose. So yes, for that loperamide, that is a good question. The max dose is because of that meperidine activity that we have, and also because it could be taking, sometimes we don't know, but it could be taking the patient a longer time for that medication to work, and then we're going to overshoot, and now they're going to be constipated. So we definitely try to make sure that we're watching out for that, and that if somebody has hit that max of the 16, it could be some other underlying condition that is going on, and they need to go into the hospital to figure out, or the clinic, and figure out what's happening. All right, I recorded the lecture for you guys. We'll see you tomorrow. Also, we're going to have Captain Lane come in to start, and he's going to start first, and then I will finish our GI lecture, okay? Have a good day.